Today, I'm here to talk about microvascular complications of diabetes. I'm Dr. Matawaran. So these are big problems of small vessels in patients with diabetes. So these are my disclosures. And for this session, we go through the significance of microvascular complications and go through general recommendations as to how to screen microvascular complications and the value of good glycemic and blood pressure control, and of course, go through specific treatments for each of the microvascular complications of diabetes. So diabetic angiopathy basically divided into two, those microvascular or microangiopathy and macrovascular or macroangiopathies caused by diabetes mellitus. So for this session, we'll be talking in particular about retinopathy, nephropathy, and neuropathy. And it goes without saying that hyperglycemia is the main driver for this complication. And this is due to repeated acute changes in cellular metabolism, the ups and downs in blood sugar, or cumulative long-term changes in stable macromolecules causing diabetic tissue damage. But aside from hyperglycemia, we have to remember that there are certain genetic determinants of individual susceptibility, particularly seen in patients developing nephropathy due to diabetic kidney disease. And of course, very important as well, independent accelerating factors like hypertension and hyperlipidemia. And that is why it is of utmost importance that in the treatment, that aside from hyperglycemia, accelerating factors like dyslipidemia, hypertension, and other cardiovascular risk for CVD be addressed in treating diabetic angiopathy. Most important, of course, is glycemic control because we are well aware that with increasing HbA1c as represented in this analysis in the DCCT showed increase in relative risk for complications or occurrence of diabetic complications, particularly microvascular complications. And any intervention that will lower HbA1c will translate to reductions in complications, in particular microvascular complications. When we saw that in type 1 diabetics in the DCCT trial, as well as in type 2 diabetics in the UKPDS, Accord Advanced, and in the VADT trial, that reductions in HbA1c produced reductions as well in microvascular complications. So this is basically the whole outline of the lecture. So we'll screen how to screen, what are the timelines for screening, and targeted interventions. And highlighted here, of course, are three main important interventions that will lower complications in the microangiopathy. So this would include glycemic control, blood pressure control, and lipid control. So we'll start first with diabetic retinopathy with regards to screening. It is recommended that initial dilated and comprehensive eye examination by an ophthalmologist or optometrist be done for patients with diabetes mellitus. They also recommend, meaning the American Diabetes Association, recommend telemedicine programs that use validated retinal photography, or what we call fundus photographs, with remote reading can be appropriate screening strategy for diabetic retinopathy. And we screen our patients, especially dependent on what type of diabetes your patient has. So for someone with type 1 diabetes, it is recommended that they are screened within 5 years after diagnosis. For type 2 diabetes, that at time of diagnosis that they be screened. And in pregnancy, those with pre-existing diabetes, meaning those with type 1 diabetes or type 2 diabetes wanting to get pregnant, that they should be screened for retinopathy prior to conception and during the first trimester, and counsel them about the risk of developing and or progression of retinopathy if it is present. So on follow-up, anytime that your patient with type 1 or type 2 diabetes have retinopathy, that they should be followed up yearly. And if it turns out negative at the initial examination, then every 2 years. For those patients who were pregnant, they should be followed up throughout pregnancy and for 1 year postpartum because of the possibility of progression. So there are treatment like optimization of blood sugar control, as well as blood pressure and serum lipid control that has been noted to reduce the risk and slow the progression of diabetic retinopathy. Specific treatment includes laser photocoagulation therapy, indicated to reduce the risk of vision loss in patients with high risk proliferative diabetic retinopathy. When we say proliferative diabetic retinopathy, there is neovascularization over the retina, as well as in clinically significant macular edema, and in some cases of severe non-proliferative diabetic retinopathy, laser photocoagulation therapy may be indicated or is indicated. So aside from that, we also have intravitreous injections of antivascular endothelial growth factor, your anti-VEGF, indicated to reduce the risk of vision loss in patients with proliferative diabetic retinopathy. Other non-specific treatment includes your phenofibrate, because we've learned in the field study or the phenofibrate intervention and event lowering in patients with diabetes that compared to those patients given placebo versus that of phenofibrate, there was actually an 31% reduction in need for diabetic retinopathy treatment. As you can see, the benefit was seen in those patients who were laser naive or those without history of retinopathy at the onset. Similarly, in the Accord Lipid and Eye study, or the Action to Control Cardiovascular Risk in Diabetes, whereby patients were given simvastatin plus placebo versus simvastatin plus phenofibrate, we also saw some improvement with regards to progression of diabetic retinopathy, translating to a 40% reduction in progression of diabetic retinopathy for those patients given phenofibrate. So that shows you non-specific treatment affecting the retina. How about diabetic kidney disease? So we all know that this is a very serious complication of diabetes, diabetic kidney disease. And aside from that outcome, we also learned that with worsening EGFR from no CKD to stage 6 to stage G5 EGFR, we see that the presence of atherosclerotic cardiovascular disease event rises. And together with that, with decreasing EGFR, there's also an increase in your non-atherosclerotic cardiovascular disease as listed in this illustration. We have to be aware, as I've said, that there are genetic susceptibility factors that may be present to increase your risk for diabetic kidney disease. But there are systemic conditions that we've mentioned, aside from hyperglycemia, of course, the presence of obesity and hypertension are very important factors that may render a patient susceptible and may render progression of diabetic kidney disease in patients with uncontrolled blood pressure and uncontrolled blood sugar. So we now use the term diabetic kidney disease in patients suffering from CKD in the presence of diabetes. But we now reserve the term diabetic nephropathy for a histopathologically confirmed diagnosis of diabetic kidney disease. So that's diabetic nephropathy. Because we have to remember that aside from the presence of diabetes, other conditions like hypertension, renal vascular disease, and other kidney disease may be present in a patient with diabetes. So that people without diabetes or factors that may be present even if you are not diabetic can be an accelerating factor or a risk factor in patients with diabetic kidney disease. And that is also very important because anytime your patient does not present with the classic diabetic nephropathy manifestation, so when we say classic, these are just patients with persistent albuminuria, blood urine sediment, slow progression of disease, low EGFR associated with overt proteinuria, those with concomitant diabetes complications like retinopathy and no duration of diabetes of more than 5 years, it means that the reason for the CKD is due to diabetes nephropathy, most likely. However, you may think of alternate diagnosis, no? Especially if you may have patients with extreme proteinuria, persistent hematuria, rapidly progressive glomerulonephritis, if you have a rapid fall in EGFR, if you have low EGFR with little or no proteinuria. Think of another condition that may have caused this the CKD. So other complications of diabetes not present, so that a patient, for example, with severe diabetic nephropathy without retinopathy. So no duration of diabetes is very acute, less than 5 years. If there's family history of non-diabetic renal disease like polycystic kidney disease, and there are signs of systemic disease like SLE, then you have to remember that those factors may not be due to diabetes alone. So with regards to screening, at least annually, a urinary albumin or spot urinary albumin creatinine ratio and estimated EGFR should be done within 5 years of duration of diabetes for type 1 and at diagnosis of type 2 diabetes. So anytime patients with diabetes and urinary albumin of more than 300 milligrams per gram creatinine or EGFR of 30 to 60 mils per minute, we label our patient with diabetic kidney disease as CKD, and they should be monitored 2 times annually to guide therapy. So this is the CKD heat map showing to us or grading, recommending grading as well as frequency of monitoring for patients suffering from CKD. So as you can see in the y-axis, so you basically have there the levels of GFR from more than 90 to less than 15. And on the x-axis, these are the levels of albuminuria from 30 milligrams per gram or 3 milligrams per millimoles to more than 300 milligrams per gram or more than 30 milligrams per millimoles. So from A1 to A3. So depending on the level of the EGFR as well as the level of the albuminuria, you eventually stage the patient and recommend the frequency of monitoring as well as recommend referral to a nephrologist. So anytime, for example, you have a patient with an EGFR of around 35%, 35 mils per minute, and albuminuria of more than 300 milligrams per gram, then you label that patient as someone with DKD G3B A3. So that would be the level of CKD for this patient with diabetes. So depending on the EGFR, the American Diabetes Association, as well as the KDIGO guidelines, recommend yearly measurement of creatinine, urinary albumin excretion, and potassium. But with decreasing EGFR, you may need to measure as well your electrolytes, your bicarbonate, your vitamin D, do bone densitometry, and referral to a to a dietitian. So for those patients with EGFR between 30 to 44, you have to monitor more frequently the EGFR. And of course, need to further refer to a nephrologist, especially in preparation for dialytic therapy for those patients with less than 30 mils per minute on EGFR. So how do we mitigate outcomes of CKD? Very important that we institute glycemic control, as we said, blood pressure control with the use of RAS inhibition to lower the risk for end-stage renal disease, aside from also managing lipid abnormalities. In the Advance On trial, which is a strategy of intensive glycemic control involving glycoside, it yielded a 21% relative risk reduction in the occurrence of nephropathy. And in the Advance On, which was the follow-up trial of the Advance, there was a significant cumulative benefit with respect to end-stage renal disease in those patients that were randomized to intensive treatment. So very important that when you do choose treatment for patients with diabetes, that we consider the characteristic anti-diabetic agents. So in particular, for example, for metformin, we usually stay away for those with CKD as well as EGFR of less than 30 mils per minute. GLP-1 receptor agonists are beneficial together with your SGLT2 inhibitor with regards to kidney outcomes, but there are recommendations with regards to lowering the not giving the medications for very low EGFR because of the loss of effectivity. So we all know that insulin is safe for patients with CKD. However, the risk for hypoglycemia rises with reduced EGFR together, just like your sulfonylurea. What is important in most of the oral medications is that DPP-4 inhibitor, as you can see, is neutral or can be used, but you have to adjust the dose depending on the DPP-4 inhibitor. So this is a very important slide showing to us how we adjust the doses of the different anti-diabetic medications. As you can see, your metformin should be reduced, the dose to about 1,000 milligrams daily if your EGFR is less than 40 and within 30, but you have to discontinue the metformin if your EGFR is less than 30. And for sulfonylurea, you have to be careful with regards to the occurrence of hypoglycemia. For DPP-4 inhibitors, you have their sitagliptin, saxagliptin, linagliptin, that may have to reduce the dose for most of their DPP-4 inhibitors, except for linagliptin, and holds the same for the GLP-1 receptor agonist and some of the SGLT2 inhibitor that we'll be discussing in particularly later. So this is the ADA-ESD recommendation in how to manage patients with type 2 diabetes. If you look at patients with CKD, as you can see on the right, you will see that the recommendation for someone with CKD that they should be given preferentially SGLT2 inhibitor with primary evidence of reducing CKD progression in the background of a maximally tolerated dose of ACE inhibitor or ARB. If SGLT2 inhibitor cannot be given, then you have to give a GLP-1 receptor agonist. And if the sugars are uncontrolled, you can combine treatment. And this is because there's this meta-analysis looking at several CV outcome trials for GLP-1 receptor agonists showing benefit with regards to broad kidney endpoint. You see there an 18% relative risk reduction in the occurrence of broad kidney outcomes with the use of GLP-1 receptor agonists, and SGLT2 inhibitor also showed a 38% relative risk reduction with regards to occurrence of broad kidney outcomes, meaning macroalbuminuria, doubling of serum creatinine, or a 40% decline in eGFR, and even ESRD or death of renal cause. So that's why these two drugs are recommended for patients with CKD. So that anytime, for example, your patient is on anti-diabetic agent, if your patient has already reached the glycemic target, yes, but can lower glycemic target safely by adding an SGLT2 inhibitor, then you may have to discontinue one other drug just to make sure that you give the SGLT2 inhibitor. But for those who are not yet at target, make sure that you do add SGLT2 inhibitor anytime you have a patient with CKD. I invite you to read the practical consideration for the use of SGLT2 inhibitor in the Asia-Pacific countries. I had the opportunity to be part of this consensus statement. And here, we give advice on how to start SGLT2 inhibitor on different conditions. So those, for example, with concomitant loop diuretic, those on NSAID, those with good glycemic control on insulin, those with history of UTI, those with ongoing mycotic infection, and those who are frail and elderly. So making sure that you know how to start and eventually reintroduce SGLT2 inhibitor in those patients with acute events. So next to glycemic control, of course, is blood pressure control. And the main recommendation for blood pressure control, as you can see in the 2018 ESC and ESH drug treatment strategy for hypertension, particularly in patients with diabetes, is that first-line treatment will be your RAS blockers, either your ACE inhibitor or ARB, plus a calcium channel blocker or a diuretic. So make sure that you start your patients with diabetes with a RAS blocker. Taking into account as well that you should not combine based on the on-target, the VA nephron-D, and the altitude trial, that you should not combine your ACE inhibitor and your ARB, because combining these two RAS blockers have been noted to increase your doubling of serum creatinine, increase the risk for dialysis as well as transplantation. So do not combine your RAS blockers. So lipid management, it has been shown. This is from the CARDS trial. This is collaborative atorvastatin study for patients with diabetes, that in those patients that were enrolled and given atorvastatin 10 milligrams versus that of placebo, who started off with albuminuria, that at the end of the study, you actually saw a less reduction in eGFR for those patients who were randomized to atorvastatin versus that of placebo. In the PLANET trial as well, wherein they enrolled both type 1 and type 2 diabetes, they were given rosuvastatin 40, rosuvastatin 10 milligrams, and atorvastatin 80 milligrams. You see that there were greater or better urinary plasma creatinine ratio was significantly lower at 52 weeks of treatment in those patients given atorvastatin 80 milligrams, and there was less mean eGFR reduction at 52 weeks in those patients given atorvastatin 80 milligrams versus rosuvastatin 40 and 10 milligrams. There's also in the DAYS study, diabetes atherosclerosis intervention study, wherein they looked at progression, regression, and no change with the use of fenofibrate, that there is some benefit with the use of this drug. So that for reduction of kidney heart risk factor, very important that we look at this great picture in this pyramid. We basically recommend healthy diet, physical activity, smoking cessation, and weight management. You can give your SGLT2 inhibitor up to an EGFR of 20 and can be continued until dialytic therapy or transplantation. You may continue your metformin, but making sure that they be continued if your EGFR is more than 30. A GLP-1 receptor agonist may be added to individualized target and other glucose-lowering medications to achieve your HbA1c target. RAS inhibition at the maximum tolerated dose for hypertension to be initiated. There are recommendations for non-steroidal MRA or mineralocorticoid receptor antagonist. You may use on top of your RAS blocker, your calcium channel blocker, your diuretic to achieve your target blood pressure. And of course, the need for moderate or high intensity statin. You may also need antiplatelet therapy, ezetimibe, PCSK9 for those patients with high cardiovascular risk. So last is diabetic neuropathy. So diabetic neuropathy is a very heterogeneous complication of diabetes. It is actually the most prevalent chronic complication of diabetes mellitus. So if you look at how we classify diabetic neuropathy, so they may present as a diffuse neuropathy, a mononeuropathy, or a radiculopathy. The most common is your distal symmetric polyneuropathy. We usually label this as your classic stocking and glove sensory loss because there is progressive loss of distal sensation correlating with loss of sensory axons due to hyperglycemia. It is also a prerequisite for Charcot neuroarthropathy and a most important cause of foot ulceration. So screening for diabetic neuropathy includes screening for distal symmetric polyneuropathy starting at diagnosis for patients with type 2 diabetes and 5 years after diagnosis of type 1 diabetes, then at least annually thereafter. We may also have to consider pre-screening for patients with pre-diabetes, and this can be done by just careful history, temperature or pinprick sensation, vibration sensation using your tuning fork, and your 10-gram monofilament testing to assess for risk for foot ulceration and amputation. Rarely do we need electrophysiologic testing or a referral to a neurologist for screening. So this is why we said that there may be need for screening in patients with prediabetes because we learned in the Monica and Cora Augsburg survey that even for patients with IGT or IFG, which are prediabetic states, that neuropathy may be present. So management, you have symptomatic relief, as you can see here. There may be topical or physical treatment, and those treated that may influence natural history, like use of like making sure that your blood sugars are controlled. In the diabetic nephropathy position statement of the American Diabetes Association, they now recommend that you may use your voltage-gated alpha and gamma ligand, your pregabalin and gabapentin as first-line treatment, your serotonin norepinephrine reuptake inhibitor, or even your tricyclic antidepressant. If there's no meaningful effect with monotherapy, you may consider switching to another agent or try combining therapy to achieve meaningful clinical effect if not tolerated. So in the Philippines, you have here a group of medications that may be given for patients with diabetic neuropathy. You have there the anticonvulsants, the antidepressant, the tricyclic antidepressants, and the opioids. But first-line treatment, at least based on several recommendations, still based on RCTs, are your anticonvulsants, your pregabalin, your gabapentin, and your duloxetine. And second line is your tricyclic antidepressants. So just to inform everyone that most of the time, use of pregabalin and your anticonvulsants it has been misused, only because they were given usually at suboptimal doses. So remember that you can start these patients at 75 milligrams once a day or even twice a day, and you have to up titrate the dose to around 300 to even at 600 milligrams daily. And remember that pregabalin is not a PRN pain medication. You also have to consider that you have to adjust the dose of pregabalin depending on the EGFR of the patient. I also had the opportunity to review the data of vitamin B, of neurotrophic vitamin B in the management of peripheral neuropathy. And in this article, we just identified those patients that may be at risk of developing B deficiency that may need your B supplementation, particularly for patients with diabetes on long-standing intake of metformin. So in summary, I've shown you the different complications of diabetes, your diabetic retinopathy, nephropathy, and neuropathy, how to screen them with regards to timeline and specific treatment that may benefit a patient to reduce or mitigate the risk of diabetic retinopathy, nephropathy, and neuropathy. So in summary, diabetic microvascular complications are primarily driven by duration of diabetes and glycemic control, and optimization of glycemic control as well as blood pressure has been shown to reduce the risk and slow the progression of microvascular complications. I should have added probably lipid control as well. And appropriate screening and specific treatment modalities are necessary to address small vessel angiopathy in patients with diabetes mellitus. With that, thank you very much and be safe.